So we'll call Professor Thomas Zeller to discuss retrievable scaffold therapy in combination with a Paclitaxel-Coated balloon, 2-year results of the deeper OUS trial. Professor.
Thank you. Well, it's my pleasure to present here the final data of the deeper out of US study. It's a repetition, but anyhow, chronic limb-threatening ischemia includes some unmet needs, and it typically involves the infrapopliteal arteries. So the treatment options did largely unchanged for decades. We have still plain balloon angioplasty as the major treatment for BTK disease, with the typical treatment failures. So we have the anatomical factors which play an important role for treatment success, which is calcification resulting in recoil, then it's drug permeability, and of course lesion length. The challenge is providing long-lasting results while leaving nothing behind. And the retrievable scaffold therapy, the so-called spur system, should overcome some of these limitations. So it's a scaffold which can be retrieved, so there's no permanent implant. It's not bioresorbable. It will be removed within the index procedure. It's easy to be positioned and released from the vessel. Again, it's a simple, familiar pin and pull delivery system with integrated balloon catheter to fully expose the stent towards the vessel wall, and in particular to guarantee that the spikes really penetrate into the plaque. And the idea behind this design is to modify the plaque and calcium to overcome recoil forces, to reduce dissections, and to improve drug uptake when used in conjunction with the DCB, as done in the deeper out of US study. So this is the overview about the trial design. It's a non-randomized single-arm study enrolling 107 patients in 10 centers in New Zealand and Europe. Principal investigators had been Dirk Scheinert, Jos Vandenberg, and Andrew Holden. There was a sub-study, a predefined sub-study evaluating vessel recoil following or looking into MLD measurements 15 minutes post-spur retrieval. That has shown that the recoil rate was in the range of 42%, which was about half of the historical numbers. The primary endpoint is primary patency of treated lesion sites based on duplex ultrasonography in subjects who are free from clinical-driven TLR, and the typical safety endpoint, which is freedom from device and procedure-related death through 30 days. Patients had been followed up to 2 years. The inclusion criteria are very straightforward. So Rutherford category 3 to 5 had been allowed to be enrolled with infrapopliteal disease and the lesion length up to 15 centimeters. Stents inside the target lesion were an exclusion criterion, as well as extremely severe calcification where a balloon couldn't be introduced for pre-dilatation. These are the typical patient demographics. Diabetes prevalence, important to realize, about 62%, and also chronic kidney disease was present in 33%. The vessel and lesion characteristics show that there was more or less even distribution between anteriotibial artery, tibiopenal trunk, and peroneal artery. Less frequently treated had been the posterior tibial artery with 13% only. The mean diameter stenosis range was 70 to 100%, and the rate of total occlusions was 25%. The spur-treated length, mean length, was roughly 93 millimeters. Despite severe calcification was an exclusion, Pax grade 3 and 4 category was present in 21% of the treated cases. Worth to note that the DZB brand was left to the discretion to the operator, and therefore a variety of different paclitaxel-coated devices had been used, some of them with negative clinical outcome results in single use without vessel preparation. If we look here into the one-year outcome analysis, then freedom from clinical target lesion, revascularization based on Rutherford category subspecification was ranging from 86% in Rutherford category 3 to 100% in 4. However, the numbers for category 4 had been pretty low. Primary patency range 63% in Rutherford category 4, up to almost 80% in Rutherford category 3, meaning claudicants. Major amputation rate in total very low. Only 1.4% of amputations, major amputations, had to be performed in Rutherford category 5. This is the summary of the entire patient cohort regarding major amputation rate. So there was one single amputation within study procedure to 6 months and no more amputation beyond the 6 months time point. So the primary safety and efficacy endpoints were met and previously reported, with 100% freedom from device and procedure-related death through 30 days, and an almost 86% patency at 6 months based on duplex ultrasound. If we look into the mortality outcome now up to 2 years, we can see that there was an overall mortality rate of 14%. Considering that the majority of patients had been suffering from critical limb ischemia, this is something what can be expected. There was no death related to the device or the procedure, as already mentioned, and the typical causes of death, including cardiovascular death and cancer, as reported here in the summary. If we look again into freedom from clinical-driven target lesion revascularization over time, at 6 months it was 89.5%, a drop of only 2% up to 2 years, and another drop of further 4% to 83.5% at 24 months. So in conclusion, safety and efficacy of the spur peripheral retrievable scaffold system followed by a paclitaxel-coated balloon is sustained through 2 years with a freedom from major amputation of 98.8%, meaning only one single above the ankle amputation, all-cause mortality of 14%, freedom from target lesion revascularization 83.5%, and patient follow-up will continue through 5 years by telephone for ongoing safety evaluation. This is based on the paclitaxel safety discussion in the past, and all-cause mortality rates support safety of paclitaxel in this patient population. Thank you very much.
Thank you so much, Professor Zeller. A couple questions about the mechanism of this and whether or not there's any imaging. Are you aware of any OCT data or other imaging data to show what's actually happening with this spur stent? And if not, do you have any thoughts on, is it allowing for a more controlled vessel expansion? Is it the deeper penetration of drug? What are your thoughts on that?
I'm not aware of OCT data. I don't know whether, do you have them?
Sorry,
Andrew can jump in here.
We did some cases with both IVUS and OCT and could see the spurs penetrating into the adventitia that doesn't really answer the mechanism of action, but it does show that the proof of concept is proved on OCT.
Yeah, and you can also see this on radiography. If you do an Zeller run with the expanded spur system, you can see the spikes penetrating into the vessel wall. So at least this mechanism of action is working in daily practice and clinical application. And well, the idea behind that is to create channels to overcome elastic recoil forces and potentially creating diffusion channels for the drug, which is then applied following the retrieval of the spur. You may be aware of the deeper Limus data combining this device with the Magic Touch Limus-coated balloon with a patency of 90% at 1 year. This is extremely high and may be related to the vessel preparation with this technology.
Thomas, congratulations. One of the things you mentioned was assessment of late recoil, and I know you led a late recoil sub-study here. Can you maybe just highlight the outcome of that and your thoughts on the incidence and importance of late recoil?
Well, we know from above-the-knee studies that recoil resulting in residual stenosis of more than 30% is predictive for restenosis development following DCB application. Whether this is also true for below the knee, we don't know yet, because we even have not robust data for a biological effective function of DCB below the knee. But in my opinion, it's very likely that in particular in smaller vessels, recoil resulting in a relevant residual stenosis is even more important than above the knee. Therefore, I believe in this concept to reduce this recoil, which is either late recoil, definitely is a structural appearance, meaning that it's related to the vessel compliance, to the vessel resistance, mainly due to calcified plaque. Early recoil can simply a mechanism of spasm. Unfortunately, within our recoil sub-study, we did not apply nitro to overcome the problem of spasm. So the rate of recoil 15 minutes following spur retrieval can be a combination of functional recoil, meaning spasm, and structural recoil induced by the vessel resistance. But anyhow, it has been shown to be 42% within the study, which is definitely an improvement as compared to the 97% of the Baumann cohort, which is usually used as a reference.
Exciting results. I had a question regarding the drug distribution into the artery. I found it interesting that you left it up to the investigators to choose which drug-coated balloon to use. Have you done any subgroup analysis to determine different excipients or drug technologies which may be more prone to have higher patency rates? Or if you haven't done that, or do you have any thoughts on different types of excipients which maybe allow better penetrance into the vessel given this technology?
You have probably seen the slide summarizing the different brands that had been used. The variability is pretty high. Some devices have been used only 8 times and so on. So it's not possible to really draw any reliable conclusion from these different numbers. But if we consider that the missing biological effect of some drug coatings may be due to resistance time of the drug, which is too short, then this kind of vessel preparation may definitely improve the performance of these devices with, let's say, minor biological efficacy. Because then, if the drug penetrates deeper into the tissue, it's less likely to get washed off thereafter by the bloodstream. So I believe there is a kind of complementary function between this kind of vessel preparation and the application of different kinds of drug-coated balloons, potentially improving their performance.
Sounds good. Thank you so much.